Good morning, everyone, and welcome. Bonjour and bienvenue. My name is Matt Raymond. I am the Director of Intellectual Property and Technology Transfer at Rush University Medical Center here on the west side of Chicago. I'll be the moderator, of course, for today's first panel discussion. I'm pumped. This is a fantastic group that we've gathered here. It should be a very lively discussion, so I'm really enthusiastic about it. We have a fantastic group of panelists. So let's get started. The program will be, for the first half an hour, there will be directed questions coming from me that the panelists and I have prepared to talk about arrhythmia and AFib. And then for the second half hour, we'll be looking to you for questions based on the discussion. When you do come up to ask a question, please use the microphone. This panel and all panels are being recorded today. And please state your name and where you're from when you ask your questions so we can have that recorded on camera. And once you do ask a question on camera, you unfortunately have given affirmation that your image can be used specifically for the purposes of the American Heart Association. So if you happen to be under witness protection or something like that, you may not wish to do that. Not my joke, someone else brought that up. So let's get started. We're joined by a fantastic panel. To my left, Dr. Uday Kumar is a cardiologist and cardiac electrophysiologist. Dr. Kumar is currently entrepreneur in residence at Third Rock Ventures, LLC, and he is the founder of iRhythm Technologies, and that's the company that produced the Zio patch. Next, Dr. David Albert. He's a physician, inventor, and serial entrepreneur. He's the founder of 3 technology companies. He's currently the Chief Medical Officer of AliveCor, and he's the creator of the iPhone ECG application. Next, Dr. Marty Burke is an expert in cardiac electrophysiology. He's the director of the Heart Rhythm Center at the University of Chicago Medicine, and he was also part of the executive leadership team for this particular event today. Next, Dr. Harry Rowland is the co-founder and CEO of Endotronix. He has a PhD in mechanical engineering, fantastic, we can always use those engineers, and he is an inventor on several issued patents and several pending patent applications. And finally, Etienne Grima, the CEO of Cardiocom Solutions. Mr. Grima is also the co-founder of the Canadian Heart Research Center, an academic clinical research organization that coordinates multi-center cardiology-based clinical trials in Canada. So again, welcome, bienvenue, thank you for joining us today. Let's go ahead and jump right into it. We're going to look in the past very briefly, then we're going to move to the future, and then we're going to try to figure out what can we do in this area of disease that can be useful to our pharmaceutical companies, to our clinicians, to our patients, to their families, et cetera. So first and foremost, I'm going to ask Marty and David, can you give us a brief description, a couple of minutes, on the state of the art for detection and treatment of arrhythmias, particularly AFib? Marty, you want to go first?
Yes, thanks, Matt, and welcome, everybody. Atrial fibrillation is really at a state of epidemic proportions, and there's really 2 basic premises. One is the detectable, or the patients who show up with clinical symptoms of atrial fibrillation, and then there's the patients who remain undetected, who are just ambiently having atrial fibrillation and not being detected. And so that's the broad epidemiologic problem. When you look at the patients with symptoms, it can be just about anything from shortness of breath to chest pain to palpitation, palpitation being where you feel like your heart's jumping out of your chest. And those patients tend to get attention sooner than the asymptomatic patients. They have the same risk, and the biggest risk is stroke. So when you're looking at the management of atrial fibrillation, you have to take into account 3 specific management decision trees. One is anticoagulation. The prevention of stroke is key. But you cannot prevent stroke if you do not have the diagnosis of atrial fibrillation. And so leaving all these undetectable patients is really a big problem. Secondly, there's rate control, where we have medications to control the patient's heart rate, versus rhythm control. In my opinion, rhythm control is the key. I'm obviously an electrophysiologist, and I'll give you that conflict of interest right away. But I'll tell you that rhythm control, frankly, sinus rhythm, is the best way to prevent stroke. And I think being aggressive in that and being preventive in that is really where the future of atrial fibrillation is going. And I think things like what Dave has worked on in getting us easy applications to get EKG data across the line in a telehealth methodology is really critical. So I'll pass it on to David then.
David?
Well, thank you. I would tell you, first of all, we have a lot of tools, but until somebody comes to a physician, they're not very useful. So if you come to your physician from a 12-lead ECG to device like Dr. Kumar's Zeo patch, 7-day, 10-day, 2-week Holter, to MCT, MCOT, CardioNet outside, all the way up to an implantable loop recorder, Medtronic's Reveal. We have many modalities to diagnose once somebody comes to a physician complaining of something. What Etienne's company and my company are trying to do is throw a much bigger net out. And both CardioCom, his company, and AliveCor mine have done studies of screening mass populations. And I think that's a brand new area, because trying to find people before they have symptoms, because as has been pointed out, stroke is you don't want stroke to be your first symptom of atrial fibrillation. And so I think that's a new modality. Is it proven? Well, next week at a big cardiology meeting, TCT, I'll be presenting on screening the general population for AFib. The European Society of Cardiology says take your pulse, know your pulse. If it's irregular, go follow up. So hopefully we have great tools once we get to the doctor. And now I think the diagnosis, like everything in healthcare, needs to go outside of the traditional path. And I think I have great optimism that we will find people, prevent strokes, put them in sinus rhythm.
Yeah, I think what Dave says is absolutely clear, that atrial fibrillation is really a diagnosis of electrocardiography, and our ability to get electrocardiographic applications to the population in general in a cheap and very effective manner is really going to be the key to the entire future.
That's a great segue to the next question, which is for Harry, Etienne, and Uday. Where is industry and medicine going in the near future when it comes to diagnosis and to management tools for arrhythmia and AFib? Etienne, please.
Thank you. It's safe to say that in all likelihood we're going to be seeing devices that are going to be easier to use and faster to communicate. I believe we're going to see a move to put these technologies more into consumers' hands and into their homes, maybe more than in hospitals and clinics. And these are going to be used both for primary and secondary prevention of disease. They're going to focus, I believe, on electrophysiological readings, ECG-based readings of the heart. And they will also likely borrow from blood pressure-based readings, because it's also been used quite a bit. The challenge will be to ensure that the technologies are developed in a credible fashion. There's a lot of technologies out there. David has mentioned the better ones. There's a lot of them out there that allow you to take a guess or an estimation of what's going on. These technologies that are going to come out, they need to follow FDA guidelines. They need to be built under ISO standards. They should be built with an idea that best practices will be applied when they're put into play. These devices are going to also need to connect to the right people who will see the data. So the physicians or the primary care individuals who are responsible for responding or managing the individuals being monitored. These are really important to keep in mind as well. We know, based on what we've seen today, the direction we're moving. We don't know what great advances are going to be in the next 5 or 10 years, but I would say that we're going to be seeing more and more sensors put into clothing. We're definitely going to see technology that's paired to our smartphones, because we live with them. We're going to see even implanted technologies, things that will lend itself to the body area networks that are being thought about. So there's a lot of future built largely on where we are today, and we have to learn to make sure that these are done in a proper manner. It's an exciting time. These guys, we're going to make sure it stays very exciting.
Harry, do you have any thoughts as well?
Sure, yeah, I think it'll be more echoing some of the themes and you know, the questions really over the next 1 to 3 years. And one of the big themes right now is connected health. So as Dave and Etienne mentioned, there's a lot of different sensor applications out there. We've made tremendous advances in that. And you're going to see different sensors for the whole spectrum of patient indications, whether it's episodic measurements, acute measurements in the ICU setting or in the hospital setting, or post-acute 30-day continuous measurements, or chronic measurements over the long term with implants. So, but all these devices are generating data. All that data is going to be communicated to physicians or machine learning tools. And I think all that's going on, that's continuing trends of what we have today, but I think there's big questions around how to use that, how to contextualize that, how to make that meaningful to patients and caregivers. And I think that's where there's a lot of work going on right now, and over the next 1 to 3 years, we might see a lot of breakthroughs in just how to make that more meaningful to everybody.
Uday, thoughts?
Yeah, I might take a little bit of a contrarian view here, is that I don't think the issue really for the next few years is going to be technologies. We have enough technologies, as everyone's alluded to. It's really going to be trying to prove in what patient population are there really actionable pieces of data based on their clinical history that it's worth monitoring, worth doing something. So I think cost is really going to be what is driving what we end up doing. It's not going to be technology. It's kind of, you know, we have a very technology-centric culture where we have the technology, what can we do with it? We really need to think about something different in the healthcare system based on the trajectory we are at, not just here, also across the world, that we need to start thinking more specifically about what are addressable event rates, what are pretest probabilities, is there a cost effectiveness for actually doing something, and also understand that all information has pros and cons. There is a negative to learning about something if it was incidental. And so we have to, and also, I mean, we see this, and there's a liability issue with that too. You know, just finding information or collecting more and more of it, there is a benefit, but there's a downside. So I think the bigger trends are not necessarily that we can't, I mean, we can sense a lot of things already. That's not the issue. The issue is how do we sense it and make it worthwhile? And I think the other thing that, you know, we spend a lot of time over where I live and work at Stanford too is really looking at the user. And by looking at the user, I mean real deep ethnographic user experience research, going out and see what motivates patients. I mean, you know, one of the examples I like to give is you can give someone an app to, get them to compete with their friends, to lose weight, but if you don't realize that they live in an environment when there's 4 fast food restaurants around their house selling very high-calorie, low-cost food, you're probably missing the bigger picture. And if you look at the biggest intervention in cardiology, or some of them, stopping smoking was a public health measure. It wasn't technology. It was public health with an update and understanding of what science has showed about the effects of smoking, and then making it a really bad thing to do and taxing a lot of it. So I think we just need to have perhaps a more balanced approach to thinking about how technologies are applied from a cost, a user, and what really incentivizes people to do something. Because the incentives are oftentimes very different than what we as physicians and people in industry think they are. Oftentimes it has nothing to do with what your assumption is. So I think those are the trends which probably are going to be more impactful, at least from what I'm seeing.
And given the Affordable Care Act and the pressure that that's going to place on pricing and the management of disease, healthcare economics is going to be an important part of the equation. You're absolutely right. And that's a perfect segue. That contrarian view is exactly what we need as scientists and clinicians to make sure that we are on the right track. Are we on the right track? Are there areas for all of the panel here where diagnosis and treatment is being neglected currently? And what are those areas, and what are the reasons for this? So, Etienne, would you like to start?
So I'm from the Canadian healthcare system. We have different traits, I'll put them, that we deal with. Quite frequently we have people who don't want to pay for services because they believe they shouldn't be paying for them. And we have other people who are willing to pay for services, they're not allowed to pay for them, or the services aren't there to be gotten. So access to care and appropriate care is an issue. You're here talking about atrial fibrillation, and we talked a little bit about screening, and we talk about screening everybody or the right people. And we had an interesting discussion yesterday about finding meaningful data in people. The challenge is, can we offer the right approach in a cost-effective manner that will, in a broad brush, give the best outcome to the most number of people? And until we have a social system and a financial system that allows us to do it, it's a challenge. So, in Canada, our issues are distances to travel and access to care. and the ability to get a physician into remote areas or get patients into a physician. And my view is that that is where we're not using even what we have today available to us properly. We can talk about what we're going to do next, but we need to figure out about how we're going to use the resources we have now. We can use what we're going to do next to help us how to do what we should do now. But it's been mentioned, we have everything we really need to do a good job available to us presently. And that, I see that as an issue. It's like bringing everything together, cost effectiveness, getting past certain social stigmas that they don't have to pay or you do have to pay, or even outpricing services sometimes, because that's still an issue.
I would,
Uday, go ahead.
well, I would say, like, to build on Etienne's point, I do think if you think about just screening for AFib, I mean, there's enough scientific literature to understand who are the people at highest order risk. So I would say being aggressive about deploying technologies in those groups and not pushing technologies in other people whose pretest probably is so low that it's not going to be worth it on a population basis is where we need to better deploy what we have, because there's clearly overutilization in certain groups of people with low events and underutilization and access to even basic care for a lot of other people. So I think it's, you know, if you look at healthcare over time being a zero-sum game, it's not that we're going to take away things from, we're doing things for people who don't need it done necessarily and really not doing a lot for people who do need it. So I think the real challenge is how do we as a community, both from industry and from the clinical and scientific side, come together and say, like, we don't want to just ration and limit care. We want to better deploy it, and that actually may be more efficacious and get rid of the stigma that technology and advancements add cost, because they don't. They shouldn't. They should be, you know, meaningful for both the patient and the healthcare system as a whole.
Yeah, I really do believe that the conversation is very true, and I think when you're a physician in the front line and you're getting all this data, and things are you know, busy, you basically need a systems-based approach to these problems, and that's where I think we lack in the United States. I think, and I'm not sure about Canada, although a lot of doctors are going up to Canada to work. I don't know what's going on. So when you look at a patient population with lack of access, that's a major problem. But we also have patients who are accessed, who have devices implanted, who have atrial fibrillation consistently on follow-up that don't have it addressed at all because the systems aren't there to address it. And I think those are the two areas that are coming out from the panel when I listen. And I think this is a major problem that we need to solve as a group. And I love the fact that the industry is up here and clinicians and clinician industry, and you know, I think that this is really the pathway that we need to take for a systems-based approach.
Does everybody know what a four-letter word is in medicine? Cost. That's the four-letter word. That I have a second-year medical student son, and they talk about cost. 35 years ago at Duke Medical School, we never talked about cost. We ordered Chem 20s every day on every patient. We didn't think about it. And that's the generation of doctors, Uday is younger than I am, but that we just thought about taking better care of our patients. We have to think about cost now. Innovation can't just be higher technology. It has to be better cost effectiveness, as Uday brought up. And you know, we talk about AFib, screening patients. We don't need to be screening 35, 40-year-old people. We need to find those people using known scientific methodologies who are CHADS 2 and screening all of them who are 65 and older. We need to find those patients with the appropriate pretest probability. What all that means is that there's a new four-letter word, but it has a positive connotation: data. And 7 words: big data, that we need to take advantage of to be appropriate in our diagnostics and appropriate in our therapeutics. Not every AFib patient needs an ablation. Some of them just need anticoagulation. But today, as Marty pointed out, there are a lot of AFib patients who should be on anticoagulation who are not. Those are strokes waiting to happen. And I hate to say it, I grew up and trained in an era where you know, we tried to fight death. But there are some things worse than death. And if you've ever seen a major stroke, in many instances for that patient, for that family, for all of us, it is worse than death. So I want to fight stroke, and that means taking advantage of data, taking advantage of the, and in America we have a problem with that. We're all about freedom and, you know, I don't want anybody to tell me what to do, and that includes doctors. We have to get over that if we're going to appropriately find and treat patients. And I hope that innovation forums like this will help guide that way.
Just kind of one comment on this topic of innovation and what's being neglected and some of these other themes is, you know, there's a lot that we can do to improve care, but we don't necessarily know the best way now. And until you're able to get out there and test and learn and figure out who the responders are and the non-responders are, you don't know until you get that experience. So I think there is potential for innovation as a global, you know, clinical research and regulatory environment, how best to learn with new technologies and new methods of care. And I think, you know, I'm at full disclosure, you know, it's very costly for me to prove out the technology we're working on, but cost of getting new innovations out there for patients to use and you know who it's going to be useful for, it's getting more and more expensive. And that means innovation gets harder and harder to get out to market, so you can't really change the system of care. So how we go about bringing new innovations to market, that's an area for innovation.
And I would,
Go ahead.
I would say that I think building on that theme is also, you know, we like to think we want to fail early and fail often. I mean, that's what we teach at Stanford all the time. But that's a difficult paradigm to use when you're talking about health. But in terms of trying to, and the U.S. is becoming more and more conservative to not allow that. And so the real balance is, because you're right, you want to make sure that what intuitively seems like a good idea is actually worth pursuing, but how do you do that in a more and more conservative environment, which it's not possible to even try things or get ethics committees or, you know, IRBs to allow, you know, use in which it's reasonable. You know, I think reasonable people would find that there are lots of situations, but because of blanket rules. So I think that's important. I think the other thing I wanted to mention is what, you know, the panel's kind of shifted. We started talking about detection of AFib. What we really should be talking about is the right outcomes of preventing stroke. Yes. AFib is only useful if if it's symptomatic and you feel it, and so you want to get rid of that, or you prevent a stroke. And so I think, in also thinking about technologies, it's not just the thing that you measure, but it's also trying to understand, and we were having a conversation about this a little earlier, that, you know, does having information a little earlier change what happens? Because for some people it will. You diagnosed it earlier. Other people, you know, it was not that important because maybe they had very rare episodes. So we also have to assume that early diagnosis in everybody is not the same. Early diagnosis, some will change. We don't want to not take into account lead and lag time biases. That's the whole prostate screening issue. You know, people are going to die with a slow indolent cancer, so does diagnosis early really make a difference? So these are the types of things as we think about diagnostics and screening that we need, that I think all payers, and I know on the venture community, we spend a lot of time looking at pharmacoeconomics of anything, even without a product, just to try to understand what you'd have to show to both balance the pros of that technology as well as the pros of not having the technology, which is the standard of care, because it's not always black and white.
So I'm hearing data, and that ties in very closely with information technology, in which we're currently in a revolution at this point. I'm hearing outcomes-based measurements. I mean, that's critically important. So you can detect, but if the detection doesn't lead to a positive outcome, then is it really that valuable? Is it going to be all that helpful? And then I'm hearing the economic aspects of this. So these are three areas that I think we're beginning to draw into in cardiac disease, in particular AFib and arrhythmia. How does the entrepreneurial community come into this? How can they take this triad of activity that needs to be advanced to the point where a clinician can now take that data and have it put into a format that they can use very quickly to do a preliminary assessment as to whether a test needs to be performed or a device needs to be used? Any thoughts on how the entrepreneurial community can assist with that, please?
Well, as an entrepreneur, here's one aspect that I think we all would appreciate. If you got 3/4 of the way here this morning and you realized you left your wallet at home, you probably just keep coming. but if you left your smartphone at home, you turn around and go back and get it. They are the remote control for your lives today. Apps are easy, they're inexpensive to develop. That doesn't mean they're all good, that doesn't mean they're all innovative, but that means that we have the world, and I'm fortunate enough to have Qualcomm as an investor in my company, and they make the chips that power most of the smartphones in the world, and they've said to me, Dave, in 5 years we'll have no dumb phones. We'll have no feature phones. The lowest cost phone in Africa, in rural India, will be a smartphone. That means that the world will be connected. So that creates great opportunities for addressing rural Canada, rural Oklahoma, rural India, and bringing healthcare, because it's a whole lot easier to move data than it is to move patients. And entrepreneurs, that's a new frontier. And entrepreneurs can take advantage of it because it's low cost. And capital efficiency is one of the new hallmarks of venture capital. Venture capitalists, I hate to say it, don't love these implantable devices nearly as much as they love capital efficient innovations. And so if we can bring capital efficiency with the innovative opportunity of mobile cloud connected data, I think there's a lot of room for entrepreneurs.
Yeah, there's a couple of, just taking it from a clinician's perspective, I think for entrepreneurs to, when they have an idea, to sit down with an epidemiologist, clinical effectiveness center of excellence, and actually get to the root issue to close the loop. What you're hearing today is we have a lot of options, we have a lot of detections that go untreated. We aren't closing the loop effectively, and I think that's where the clinical effectiveness, the big data that Dave brings up, and Uday's hit on it, and I think it's really the end game, right? I mean, the cost, effectiveness, and the clinical effectiveness go hand in hand, and I think if the entrepreneur sits down at the front end like that, and partners with the academic centers and with these big groups that have networks throughout the world. Dave's talking about a global health economy, a global health clinical effectiveness, and I think those are the key features that I think will close the loop and make it much more beneficial to the patients.
So,
Please.
one of the things about being entrepreneurial is that you sometimes forget that other people are also entrepreneurial. And many of us can only carry the ball so far. And a very important aspect of developing ideas is to go to people who are more grounded in the application of where you think your technology is going to go. But you also have to realize, and this is the opportunity for the next entrepreneur, the one you hand off to, they are going to be just as important as we might be in coming up with an idea. Maybe we can commercialize the idea. But there's this aspect that the FDA has taught me, which is about intended use. How do you intend to do anything? Why are you doing it, and what's the intention? So I have intentions, and I think they're great. But I don't know what's going to happen with technology, or even my life, or the way the companies, or the countries, or anything is going to happen with patients. So the opportunity is vast, just as a spin-off economy would be, that there are going to be lots of entrepreneurs that we should be encouraging to pick up on what we're doing. So it's, when I sort of heard the question, I thought about what's the entrepreneur, me, or David, or Harry, what are we going to do? It's actually, what's the next person we're going to enable to do something more? And there's so much more potential if we can develop that, or we can realize that and accept that and facilitate that, which I know the AHA is active in doing. The idea is to try to promote this. So the entrepreneurs who are working today, their biggest opportunity is going to be to find the opportunity to work with entrepreneurs from tomorrow and to leverage that.
And I would say that I think if you're an entrepreneur today, in a lot of the companies I've started, the first thing I want to learn is who is not drinking my Kool-Aid, because I am. So you really want to make sure that you don't just, and you have to be very passionate about what you're doing. It's very, very, very important, but critically now, unlike probably not even that long ago, 5, 10 years ago, where for any type of startup environment, angel investor, venture capitalists, you had a very big problem with a big market size and a very cool insight or cool way of solving it. That was needed. We'd figure out how to get it regulated and paid for later. Now, if you're a smart entrepreneur, you should almost start with the pharmacoeconomic case up front of why this is a worthwhile problem to solve. Then figure out, is your solution, can it fit in what is pharmacoeconomically possible? And then go talk to people to validate, if I did this and it cost this much. I mean, you know, I just came from Boston where we had a meeting at Third Rock, and we brought in people from like the CEO of Geisinger, Blue Cross, to just look at new ideas, which we're not even doing yet, just to try to understand. I mean, the world has changed where, you know, and I think it's also important for entrepreneurs to understand that the physician is not really your customer anymore. Physicians will definitely buy stuff, but as practices get bought, as you know, hospitals and other integrated systems get bigger, it's the service lines. You know, it's like who's buying for all of cardiology, who's buying for all of, you know, all of the different products. It's a different purchaser. So insofar as you can get clinicians and patients to really buy into your idea, that should be a de facto. You should have something that, you know, works for both of them. But ultimately, they're not the ones who are going to say yay or nay to your product. It'll be a payer based on lots of physicians telling their service line chiefs, we need this is going to help us. So I think you have to think about, as an entrepreneur, all of these things, which is beyond engineering and beyond medicine, but actually really how the world's working these days, if you have even a shot of getting the limited amount of dollars that exist out there to fund startups these days.
Really, what?
I'm going to stop us there. I'm going to ask one more question before I open it up to the group. And that one question is off of the sheet, and that is, we have representatives from Janssen and Boehringer Ingelheim here. So we've got big pharma, big biotech is involved in this. How do they guide what you're describing? How do they get involved in the assistance of the entrepreneurial community to provide this supporting information that can help them as a company achieve their bottom line goals?
Well, I can comment that, you know, I think what we're seeing across the industries, both in life science, biotech, and even in medtech, is the percentage of spend on R&D and new technologies as a percentage of sales is going down, because I think a lot of big companies have realized while they're very, very good at distributing, manufacturing, and selling products, finding new areas of unmet need and developing new technologies based on their cost structure and timelines to do so is maybe not the most efficient. So what we're also seeing is how, and we, you know, in the past, it was kind of a taboo when you were early entrepreneur to go talk to the company that could acquire you, or it could be, because they might get an idea and go do it, but that doesn't really happen. If anything, things have flipped now that we want to go talk to all the strategics about our ideas up front, saying like, is this something that is in your white space, you know, in your 10-year plan? Is it in your 5-year plan for adjacent opportunities? Is it something you're working on? Oh, great, well, you're working on it, well, that's interesting to know. So trying to understand what they're doing so that they can help either partner earlier. We're seeing earlier and earlier investments in new ideas from life science companies have been doing it. We, at Third Rock, we've had a lot of investments in pharmaceuticals. Earlier in some of the biotechs, we do partnerships, non-dilutive funding, and it's starting to spill over to medtech too. So I think it's more where the industry's always had to go, that if the big pharma, big biotechs and medtechs are good at distributing, selling, manufacturing, and having all the relationships, and startups are really good at figuring out problems to solve and efficiently building solutions, it's better that these little companies trying to build out a whole sales force for everything, it doesn't make sense. So I think that's where the alignment could be probably a good outcome of what's happening.
Yeah, I would even go further and say that, you know, I look at big pharma, big device companies as really the purveyor of allowing us to get the big data. Like, I see them as key partners. I know early investment, and they've become sort of in a selective sense, a little bit more VC, with small amounts of investments in these new startups, but really they have the ability and the finances to get a lot of this big data, and I think I would send that shout out to them that they should continue and really focus in on that, because it's going to be very important to close the loop for you guys to do what you need to do.
I have one other point. Our gold sponsor, Janssen Pharmaceuticals. You can turn on TV and see an ad direct to consumer for Xarelto. If anybody understands where healthcare is going in the United States, large deductibles, larger deductibles, personal financial responsibility. Does anybody think it's going to go down?
No.
It's going to go up, which means patients are going to have to pay. That means we're going to have to go to patients, not to doctors, not to hospitals. Yeah, they're going to buy stuff, but Etienne's already selling direct to consumer. We will be selling direct to consumer. Consumers will be responsible, and if they're responsible, they're going to want to have say. So big companies know how to market to them. Little companies do not. We are going to need their help. You know, Apple is a genius at marketing to the consumer globally. We need their genius to help us. J&J is a genius. Boehringer Ingelheim's a genius. They have resources. Entrepreneurs will need, as Uday said, to partner with them because you're not going to be able to address the billions of potential customers as they pay out of their pocket to deal with their health. But that clearly is the tsunami that is coming.
So I can add a comment on that. I think, again, just echoing the themes, you know, the big companies are good at things that require infrastructure. So the commercialization, the marketing, distributing products, and small companies are good at just really condensing information into a small group that can move quickly. So I think the communication and support on the front end for these are the areas we need help on. We have a dialogue with startups, and it's outsourced R&D. It's almost like just X Prize is startups. You guys go work on this. We'll support funding at different levels, and whoever wins, we'll fold you into the mothership and we'll distribute the product. So I think just more of that, just understanding of what big companies do good and what small companies do good, and just having open dialogue and financial support along the way as well.
Excellent. I learned some things here. I learned things that I can now guide my entrepreneurs coming out of Rush a little bit better. But now is the time for you to ask this panel the questions that are burning in your mind. Once again, I request that you come up and talk into the microphone because you are being videotaped, and you let us know your name and the company, institution, organization that you're from. So the first question, anybody have a burning question in their minds? Please.
Good morning. My name is Rod Passman. I am an electrophysiologist at Northwestern University. We all know that AFib causes stroke. We all know that we have wonderful medications to prevent stroke once we find AFib. And yet we're talking about that we need to prove that finding AFib early by a screening method and intervening early prevents outcomes. Do we really need to prove that? I mean, that's a very large study to prove that, and yet we all want that data. I mean, we're talking about a diagnostic test. Right? We know that a lot of strokes that occur in patients with AFib, the stroke is the first manifestation, as you pointed out. So do we really need to reinvent the wheel, that finding AFib early and intervening early prevents outcomes, or can we just say that we found this disease, we know this disease is a bad one, we know we have effective treatments? And who's going to sponsor that trial, that 20,000 patient 10-year trial?
Well, go ahead, Martin.
Yeah, thank you. That's a tough question. Thanks, Rod. I think that the big issue is not in the clinical arena in that question. I think we definitely are 100% behind treating atrial fibrillation. I think where it breaks down, and what you were hearing from a lot of the entrepreneurs on the panel, is the cost issue, and to get the ability to get paid for the screening tool is really what's at play here. And third-party payers, even the government, do a lousy job at accepting the bare facts that when we detect this, that we're doing a good thing for our human brethren and to our patients that we're treating. And I think when we don't get reimbursed for a system that is doing a good job and makes a lot of sense and is going to allow for better compliance from patients and easier access that currently isn't being realized, I think that that's a major disconnect between our third-party payers. And I mean, in Zeopatch alone, I mean, it was nearly impossible to get a CPT code. I mean, maybe you can talk to that, but I think that is a major impediment that data fixes. And they want the data and the clinical effectiveness that Don's working on to actually answer those questions. And unfortunately, those are in very large studies. But I think that's where big pharma and big device companies need to come in and help us and pass the baton like Etienne's talking about to actually give us the tools and the reimbursement that we can actually apply then. I think it's a great question, Rod. I mean, I agree with you. I'll treat anybody with AFib. I'll ablate them too, Dave, sorry.
Well, I would like to say that, you know, one of the things we're looking at here is, you know, there's a welcome to Medicare physical, and an ECG is not covered.
Exactly.
They pulled it out to put in talking about end-of-life care. They made that trade, okay?
It's a $6
Does
test
everyone
for Medicare.
understand?
$6.
So that means that screening is not paid for in a 65-year-old. And anyone who knows about the demographics of AFib understand that it becomes an exponential increase in the incidence of AFib with age over 60. It's exponential. So it's over 10% over the age of 80. How do we rationalize that? It will be data. And you know, if we can't get someone to fund NIH to fund a ginormous study, then we're going to have to meta-analysis this data and go and prove, again, that four-letter word, that the cost is worth the value, okay? So, ladies and gentlemen, that's a challenge, no question.
I would say, and Rod, that's a great segue, because you know what I see is you do that 10-year study, you do the 20,000 patients, and it's not even taking into account being flexible to actually take on the new entrepreneurial things that come down the pike in that 10-year period. And I think that has to change. I mean, I think that has to have the flexibility, and NIH has to know that, and researchers have to apply that. And I think that would help the entrepreneurial group too.
You know, I think, Rod, I think everything you've heard is right, is that it's not the people don't believe that finding AFib doesn't treat it. It's more that, you know, for any given patient, they're an N of 1, but you know, the example that you just gave, Dave, we know that the last month of care is the most costly piece of care. So if discussing hospice and other types of alternatives can prevent a prolonged hospitalization at the end of the care, that adds up to a lot of $6 EKGs. So I think we can sit here and say that, well, yeah, why are those trades being made? But you have to look at it in the natural history of all diseases and all things that will happen to the patient. So that, you know, when you're trying to determine in which population should we find AFib and then treat it, well, that means that if you're paying for this, something else is not either being addressed. I mean, I wish it wasn't that way, but it is that way. You know, so I think it's really less about clinical. We know the clinical. It's more that how do you show, and maybe it's modeling, maybe it's cost-effective analysis, I don't know. But you have to show that finding AFib is in the right population, that even that is still going to offset other things that we were trading for. So it's definitely about cost. I don't think it's about the clinical. But if it was free, then I think people were like, okay, go ahead. But it's not. And I think, and like I said, there's also a cost to the care. And so, like I do think it's not a zero-sum game, and we, particularly as EPs, may look at our things we do in a very small box, but even among EPs, amongst cardiology conditions, you know, people deal with hypertension. There's a lot of other things the healthcare system's spending for them. And then as they get older, arthritis, oncology, other things. So, you know, it just keeps adding up. So I think while it's intuitively obvious, the more that we can define a high pretest population, the more likely we'll actually get a bite that you could then expand from. I think when we go for these massive indications up front, it actually works in reverse. That then, well, we're not going to do any of it, as opposed to saying, oh, that seems reasonable for this high group. Let's then build from there.
So just a spin on this. If anybody in this room was told that they're at high risk for AFib and stroke, and you could pay $6 to be screened, how many would pay the $6? Okay. So now your screening is funded. So this is the challenge, you know, the consumer will decide a lot of what's going to happen. You know, we've been working to try to put screening into the hands of people who deal with other people, so pharmacists, physical trainers, chiropractors, who, when, you know, if I said, you need one of my products because it's great, you're going to go, well, what else are you going to say to me? I'm not going to buy your product, even if I need it, because it's you saying it, but if a
Eddie,
trusted
I'll
person,
buy your product.
thank you. But if a trusted person was to say that, it has some weight with that person. So if you could develop an approach, because the question originally was about this, the use of pharmaceutical companies' leverage. They know key opinion leaders. There's real smart people working in the pharma companies. They have access to consumers. They have access to big data. They generate a lot of big data. We have an ability to perhaps push this down a bit to the front lines and stop leaning on the NIH or the government or healthcare, and giving people the chance to say, I will pay a little bit because I'm at risk. I have qualified people telling me this. I have qualified tools that will identify my risk, and I'll pay some money, so I'm not the 1/3 of the people who, are disabled terribly after a stroke. And this is almost a taboo in Canada to talk about, is to get people to pay for their own care. It's like extra billing. But it's entirely appropriate when you've lived through it. If you've seen God once, you're certainly heightened to your mortality and the benefit that a couple of dollars well spent can do to help you. So I don't think it's that far off, but we have to sort of move away from the paradigm that we want other people to pay.
But it's somewhere in between, right? It's
Absolutely.
Not, so, I mean, I think what you've hit down is important. I think patients want physicians to tell them, well, what do you think, doc? I mean, they want them to tell them, like, you should, I mean, obviously beyond just go exercise, eat less, and stop smoking. I mean, things like this. You're getting on in years, you should do something. I think it's different than just providing tools out there and then having consumers be able to figure out what they should buy and use. Because, blood pressure cuffs, you can buy any Walgreens. Right. It's not like everyone's going and taking their blood pressure, even though probably people do have stressful lives and are at risk and probably have a lot of essential hypertension. So I think, though, the ones who are told by their physician, you should monitor this because, we took it once or whatever. I think there's an intermediate that may eventually get, particularly in other economies where there is no reimbursement.
Exactly.
It's a different model.
We're addicted to third-party pay.
Right.
Yes.
We are. And people think the first dollar, which is why I said the new trend, GE, I worked for GE, I sold them a company. Their trend is big deductible up front. So families, $5,000, $7,000, $8,000. That's going to create a new paradigm among people who, by the way, are well off. But they've, in the past, thought $1. Does anybody here know how hard it is to get into a doctor in December? My wife's a rheumatologist. Everybody's arthritis flares in December. No. But the point is, we've trained ourselves. No one goes to the doctor in January. Everybody wants to go in December. We've trained ourselves. We need to untrain ourselves.
Okay, thank you. Another question? Please.
I know you can't see me here, but I'm Annabelle Vogtman. I'm a cardiologist at Rush. I'm an electrophysiologist by training, but I run the Rush Heart Center for Women. And as you all know, women have a higher risk of stroke, but when they're in atrial fibrillation, but they're actually not treated as aggressively. And I'd like to change that through education and identification of the risks. One of the things that I think that the American Heart Association can do is really to promote identifying who's at high risk. As you all stated, that people who are at high risk for stroke don't even know that they are. If you have a CHAD score of 1, oftentimes the physician and the patient will choose to just put them on aspirin, and that's the wrong thing to do. And I think that the American Heart Association can play a role in posting, if you are at risk for atrial fibrillation, these are your risks. Are you a CHADS 1 score? Are you a CHADS 2 score? That's so easy to do. And they can just have posters in the patients, in the physicians' offices, in the waiting rooms. Educating the public is key to getting to these patients. Unfortunately, we still don't have the answers for a lot of these patients who are CHADS 1 score. It's easy when they're CHADS 2 score. By the way, CHADS is an algorithm that we use to identify who's at high risk for stroke. If they have heart failure, if they have hypertension, if they're older, over 65 years old, and sometimes even 75 years old is the cutoff for identifying these patients at high risk for stroke. if they have diabetes, if they have a stroke. That's what the CHAD score is. But we need to educate the public about this, and it's an easy thing to do. The American Heart Association is great at educating people. That's something that we can do. You know, just have posters in physicians' offices to identify these, because I've seen way too many disabled people from atrial fibrillation strokes, and I don't want to see any more. Thank you.
Just a comment on that, tying in the theme of the panel meeting is really around innovation and IT, mobile devices being everywhere. That's a new platform to reach patients. So it's maybe in the past, you know, we're doing posters and things, but there's an opportunity for entrepreneurs to figure out how to distribute health information in an engaging way to where you can reach patients. They're going to read it. They're not going to walk by it. And so you can get that to them. You broadcast to 5 billion patients, and you get the pickup that you need to identify more events. So I think that's an area, low cost, the tools are out there to innovate and really impact patients.
I think there's another way, to think about it, because I think, health is one of those things. Everyone doesn't want to think that they're getting older or sicker. It's not something that people want to be.
I'm not getting older.
But I think, we can take the page out of other things. I have 3 little kids, and, they know exactly when they need to get vaccinated. If you look at, various healthcare systems, they get alerts. Have you asked about tetanus? Have you asked about this? There's very simple things that when you go to your primary care, who are typically the first-line providers, so they don't know they have a cardiologist, that, forward-looking healthcare systems put into, these are the things that have to be asked, so that, for something like this, I would say it's maybe a more efficacious route, because yes, some patients will probably figure out that I need to go ask my doctor about whether I need to be screened. I think more likely is if primary care have a list of things that they should be asking once a person hits a certain age, because these are very simple things to do in checklists, but again, those one could put into checklists unless societies tell people doing that, because these are the metrics they're going to be, because again, if they are not doing this and they have higher incidence of stroke in their populations within a different type of outcomes-based healthcare system, they'll be dinged. So there's a likelihood, as we're moving to a more outcomes and not a click chart system, that something like this actually should be done, and actually it'll be financially beneficial, which is oftentimes, unfortunately, a main incentive of why things get asked or don't asked at the physician's office.
So one interesting point that you struggle with when you have a company and trying to market something is your market needs to know that they're the market. And you've identified that people at risk don't know they're at risk. And the doctor telling the patient they're at risk works. I can tell you that in Canada, people don't have a regular physician. There were lotteries and people were cast out of practices because of funding changes. And now a lot of them rely on walk-in clinics. And until we have one EMR system, you can go get all sorts of nice prescriptions from multiple locations in 1 month until the systems are better coordinated. But because of that, there isn't that engagement, repeated engagement between a physician and a patient. So they're not actually getting the right message consistently to understand that they're the market or they're at risk to actually accept the recommendation from these people. So you do need tools out there. You do need to have it, I don't want to say dumbed down, but it has to be bite-sized, sometimes sequentially released. And then people, the soil is fertile for them to get to the next path or process in getting treated. So if I can ever get to see this guy, I'd be real happy, but there's a lot of barriers.
That's not nice, Eddie.
Yes.
Well, I'll throw out a quick solution here for you, Annabella, and that would be in the EMR, as you're evaluating the patient, you have checkboxes that you can do that would link to applications that then, with a single device that could be created by an entrepreneur, that patient could then take their smartphone and immediately download those 3, 5, 10 apps that you feel are appropriate for that patient to use to manage their care. And so you're the primary provider, and you're seeing that they have the option to download these apps, have them on their smartphones, and kind of know how to use those applications, which would be a poster, but really using the smart technology now. I don't know if something like that exists.
Well, it would be nice, like we talked about pharma, but imagine if Apple, Samsung, AT&T, Verizon built into their phones, which they could do, screening apps to look at your CHAD score, okay? They have the power to do that. They have the reach. China Mobile, 600 million subscribers in a country that cares. I mean, it's unbelievable. I grew up where it was Red China, but they actually care about their population. I know we care about our population, and the cost to AT&T or Verizon or Apple, zero.
Nominal.
Zero.
Absolutely not.
So how can we get them to embrace public health?
Great.
That's a challenge.
We have time for one more question, please.
I'm Alan Anderson. I'm a cardiologist from Northwestern. I'm actually a heart failure specialist, so I'm actually in the growth industry in cardiology. That's exactly the point that I want to make. What you need is iDoc and iDoc Pro, right? And iDoc, everybody downloads on there. It's a suite. It has risk stratification profiles. You can dumb down CHADS to an intelligent person. You can do heart failure risk, you can do hypertension. You pick the major chronic diseases, right? You know, and again, and target the patient, give them a little bit of information. And then if they actually do go to see their doc, then they get a more sophisticated version of that. I would argue, I think the target population is the consumer, is the patient. I think the target consumer for a lot of these things is the patient. You can have iDoc EKG. So, you know, if you can get over the fact that you're not going to get, you know, $500 per hit and make your cost on the back, or reap your benefit on the back end when they do the iDoc and they find out that, gee, this EKG is abnormal, you know, go see your doctor or something like that, and they actually show up. And so some of those people are not going to have an abnormal EKG, but their lipids are going to be high, or they're going to have hypertension, or their glucose is going to be high. And then you'll pick up the other folks. Part of it is getting them in the door in a cost-effective way, because they don't show up.
I would say that. I think that's right for certain sets of patients, but I do think that I would always caution that we make assumptions about patients' lives. Most patients work very, very hard. They have lots of different stresses in their lives, multiple jobs, children, mortgages, putting food on the table. They're not all, smartphone wielding. I'm on, using apps all the time. I'm not saying that they don't or they couldn't and a subset wouldn't. But I'm saying, like, if you want to really affect something that they use consistently, not just for a month or two and then, it's a novelty that wears away, it's a much more deep understanding of what patients have to do. And it's not just providing with a map. Because you can get a lot of people to use an app quickly and then it kind of fizzles out. So I just think that, yes, there are going to be motivated patients who will do it. I mean, if you look at kind of the mobile health and also the fitness industry, a lot of those original 5-6 years when stuff came out was to help people who were at risk, not, were overweight, get better. But what's happened is the people who really use those things religiously are the people who are already fit, and they want to get more fit. And so they want to compete with their friends to shave off. So I'm just saying that I'm not saying there's not a role. I think we just have to be more judicious about it to figure out where we can actually have a beachhead to then expand from.
Well, what you got to remember is, I completely agree with you about the patient, but who will use it is their kid.
Yes, yes.
And what you have to realize is, I mean, we're about to hit the wave of baby boomers, and they're not all plugged in. I don't Twitter, and I'm barely a baby boomer. But the kids coming along behind them will, and that will be the paradigm for that population that is coming up.
And I think you hit on something that goes back to an earlier comment about incentives. So for a patient who's not that plugged in, who's sick and who lives a certain way, it's a different. But if you're the child of a parent who's sick, your incentive to see them get healthy is different. So you may actually do things to just make sure grandma or mom is doing well. Or for instance, like I have little kids, like I said, so I do things regarding my health because I want to live for a long period of time to see them. So my incentives change. But it's really, I think, I do think that there's a balance between just focusing on the patient versus the care structure as a whole, where there might be real insights into where to target some of these technologies.
Other thoughts?
The chief medical officer of any family is the mom. It's the alpha daughter. She's taking care of the kids. She's taking care of the parents. okay?
And the husband.
The husband, exactly. She's scheduling the doctor's appointments that he doesn't really want to go to. Colonoscopies, prostate exams, all those wonderful things. I'm over 50. I've been there, done that. So I would just tell you that should be a focus, because that's the reality. They go to the pharmacy. They get the prescriptions for their parents. They make sure they're okay. They make sure they get to their appointments. And so if you're a marketer, if you're Janssen, Boehringer Ingelheim, Cardiocom, we need to focus on the alpha daughters, because they are going to help us bridge this gap. And you know, inevitably, you're right, the lowest penetration of smartphones are people over 65. It's only 15 to 20%, but it's going up every month because they're not going to have a choice. It's going to be the only phone they can get, and the alpha daughter is going to get it for them and going to load the right apps. So there's the focus. Those women, hopefully wearing red dresses, who are focused on the health of everyone else. And by the way, we need to let them focus on their health too. So.
One other comment I'd make is that, you know, if you watch enough cable news, you probably see more Viagra and Cialis commercials than you'd ever want to see. And occasionally you'll see a direct-to-consumer for Xarelto. But what's interesting is that, you know, unlike ED, where everyone will watch it, and now testosterone is the new big thing, it's like a new disease. But because the people watching it directly affects them. But I would say that, again, if you want to do things which are happening, you might want to change marketing, saying like, do you have a loved one, or is your parent of this, this, or this? To get to your point, because it might actually resonate more in a different way for someone who's more likely to pay attention to, oh, that's interesting, I never knew that. So I'm just thinking there's a lot of ways we're already doing that could probably be more efficacious.
You know, the couple of points in the end of this has come up. It's not always the people who are at risk that are also going to be offering the benefit, you know, the alpha daughter. You know, in my house, the chief technical officer is my son.
Yes.
The teenager. And I don't use Twitter either. I don't know if I should. Apparently, I'm told I should.
You should follow Dave on Twitter. He's
Yes,
very good.
yes. I've tried. But adoption and entrepreneurial ideas, we're also on a wave of new ways of communicating. My kids, they have cell phones. They actually don't talk on them.
That's right.
Right? They're all the time doing this.
The
And I
orthopedist,
don't
thumb
understand-
specialists are going to have a lot of business.
Yes.
No one wants a voicemail.
So we have a whole new way of communicating and implementing and transferring information that, you know, maybe you guys are a lot smarter than me and you're doing it already, but it's like an underground economy that's going to become the economy.
Absolutely.
And we're going to be out of the loop. And that's another part that, you know, we're trying to understand and make use of, because it can be used in communicating about your health.
I'd like to,
Unfortunately, we're out of time. It is 10 o'clock, and I'm sorry, we're going to have to ask the question at a later time. I apologize for that. We have another panel that's coming up. I would like to say this one thing. We need an outcome here, and the outcome can be AHA-driven. So we've identified some issues, some problems. We've identified how the different involved parties could work together to identify which of those issues actually are economically viable, both in the healthcare arena and in the commercial side, so that they do generate income for revenue for a company. So, you know, an outcome here potentially could be that we, as essentially members of this panel and members of this forum, come together, use our expertise to identify those various areas of the overall pie that are going to dictate healthcare for the future. And if we can say that this makes economic sense, and we've also been able to bring in the FDA through BI or through Janssen, then we can convince them that this is the type of thing that should be billed for, it should receive a proper coding for, it is appropriate for this population of patients. So let's be thinking in that direction for this first forum. How do we come up with an outcome-based approach with these ideas and get entrepreneurs involved so that they can take them and turn them into products? So I'd like you all to join me in a round of thank you for our panel.